Alright, well here we are at Pulmonary Part II, second set of the pulmonary chapter. After finishing up ACLS, I'm sure you'll be pleased to move into the pulmonary part of the paramedic program. So we're going to continue with some non-traumatic lung diseases that include acute lung injury and acute respiratory distress syndrome. Now, some people will still refer to ARDS as adult respiratory distress syndrome, but we know it can occur in children. Acute lung injury is a precursor to ARDS. Essentially, they both present the same way as a result of alveoli that's been damaged from either illness or injury, and as a result, there's an impairment of oxygen and CO2 exchange. So the patient gets severely hypoxic, they get hypercarbic, throw in some pulmonary edema, and eventually, if left untreated, leads to respiratory failure. Both an acute lung injury and ARDS has a really high mortality rate. So with our acute respiratory distress syndrome, some of the possible triggers: aspirate pneumonia certainly could cause ARDS, cardiopulmonary bypass surgery, sepsis, multiple blood transfusions, oxygen toxicity, trauma or burns to the respiratory tract, pneumonia, tuberculosis. And some of the history and physical findings that you're going to have with ARDS is that there'll be some sort of history of a massive insult to the body. Signs are going to include shortness of breath, rapid breathing, inadequate oxygenation, high CO2 levels, and decreased lung compliance as a result of the pulmonary edema. So how are we going to treat it? Well, essentially we're going to administer them oxygen, but if there is pulmonary edema, preventing the exchange of oxygen and carbon dioxide, then we're going to have to think about how we're going to deliver that oxygen. We'll use a pulse oximeter, certainly a capnographer, heart monitor, to assess the effectiveness of oxygenation and ventilation, and provide some positive end expiratory pressure with a BVM if SATs don't improve with just the administration of oxygen by cannula or mask. And then if while doing the BVM, if the patient is conscious and there's evidence of pulmonary edema and shortness of breath, we're going to start them on some CPAP. Ray will be going over that in the labs on how to use the CPAP, set it up, the pressures we start with, and all those sort of wonderful things. And if CPAP is not successful, or it's not appropriate to give CPAP, like in a patient who has an altered mental status, they're not a candidate to use CPAP, then we might have to do a rapid sequence airway. And that might include sedation and a King, or sedation and paralysis and an endotracheal tube. Asthma is one form of obstructive and restrictive pulmonary disease, or what we like to call COPD, chronic obstructive pulmonary disease. It includes a variety of diseases like asthma, like emphysema, like bronchitis. And asthma is also known as a reactive airway disease because you have asthma, but you're not always having an asthma attack. You're not always wheezing, those sort of things. But there's a trigger or something that your airway reacts to that trigger, causing a increased secretion of mucus and tightening of the bronchioles. With asthma, patients are often able to maintain normal acid-base balance. They're able to move enough air to prevent respiratory acidosis. But if the attack is prolonged and they don't get relief, it can lead to respiratory acidosis. And asthma, the components of asthma include bronchospasm, so the bronchioles narrow, bronchial edema, so the bronchioles themselves swell, and then they secrete excess mucus. Some of the triggers of asthma include allergies, middle or lower airways develop edema, bronchial smooth muscle contraction, bronchial wall edema and thickening, thick secretions, and it's often preceded by a upper respiratory infection. So some sort of URI may trigger an asthma attack. Allergies may trigger an asthma attack. Being exposed to certain fumes might trigger an asthma attack. Stress can trigger an asthma attack. So there's a wide variety of triggers, but the lower airways swell, the smooth muscle contracts, the bronchial walls thicken, and secretions are produced. And it's, again, exposure to that trigger that's going to cause an acute onset of respiratory distress. The other thing that's really complicated about asthma is asthma patients usually don't have trouble getting air in, but because of the narrow bronchioles and the mucus, they may have trouble getting air out. So that leads to air trapping and hyperinflation of the lungs, and you can clearly see this on end-tidal CO2, and that's one of the nice things about monitoring end-tidal CO2. The shark fin appearance of the waveform lets you know that the patient is in bronchospasm, but then when that baseline elevates above 0, you know that they're trapping air and they're not adequately exhaling, and that can, pre-warn you to the need for aggressive asthma management, or maybe even intubation. They're going to have some chest tightness. It's going to be very hard for them to breathe. It's important that when you're obtaining a history of an asthma patient that you try to find out if this attack is similar to the past episodes that they've had, and then what's worked and what's not worked for them, and if they have a prescribed inhaler, did they use it? If a person only has an inhaler that is a corticosteroid, or some sort of steroid, anti-inflammatory steroid, that's not something we would use emergently on this asthma patient. Their inhaler needs to be a rescue inhaler that has a beta-2 agonist that will help dilate those bronchioles so that they can breathe. Other medications may cause the attack as well as inhibit treatment. And as an example, we had talked in our cardiac section about aspirin-induced asthma in patients in their 30s and 40s who have asthma, who you give aspirin to during their heart attack or their acute coronary syndrome, and they develop an asthma attack. Beta blockers may inhibit the treatment for asthma, because certainly one of the treatments that we give an asthma patient is a breathing treatment, which is a beta stimulator, a beta agonist. And if we've given beta blockers, or they take beta blockers, it may be harder for those medications to work. If you've got a person sitting up in the tripod position, leaning forward, heads in the sniffing position as well, you know that they're extremely short of breath. They're going to have difficulty breathing. You can sometimes hear the wheezing as you walk into the room. They're going to have a cough, but the mucus that they cough up is extremely thick and very difficult to clear. And sometimes it is helpful if we establish an IV and give some fluid boluses to help loosen up that mucus. We're also hoping that the nebulized treatment, that additional moisture that they're breathing in, helps loosen up that mucus as well. It's important to distinguish between clear and absent lung sounds. If our patient's got clear lung sounds, that's a good sign. If they're wheezing, that certainly is a bad sign. And if their wheezing goes away, that may be a good sign, or it may be a bad sign. For us to wheeze, for us to whistle, we got to move enough air. And if they clamp down real tight during their attack and they're not moving much air, they're not going to be able to wheeze, and you're going to hear that. Some other findings of asthma include anxiety, agitation, rapid breathing, rapid heart rate, speaking in 2 or 3 word sentences, prolonged expiratory wheezes, pallor or cyanosis, decreased muscle tone, and increased accessory muscle use. Some signs of impending respiratory failure in an asthma patient include fatigue. Remember that work of breathing is an active process that requires energy. And the longer and harder that work of breathing continues, the more likely the chance is that they will become fatigued. Absent breath sounds if they're not moving enough air, severe hypoxia, SATs less than 84%, severe hypercarbia, end-tidal CO2s greater than 60, profound diaphoresis, altered mental status. All these are signs of impending respiratory failure. One of the things that's being used in some EMS systems is called a peak flow meter. And the purpose of a peak flow meter is to measure the maximum exhalation that a person can do. You place this in the patient's mouth, they take in a deep breath, and then they exhale as hard as they can. And you do that 3 times and take the highest reading. Then you give them a breathing treatment, and then you measure that again. And certainly we would expect their ability to get rid of air to be much more improved after a breathing treatment. If we don't see a improvement in their peak flow, then it may not be narrowed bronchioles, or the treatment just didn't do them any good. On the capnography, as I had mentioned, you're going to see a prolonged expiration before the shark fin waveform. And when you see that shark fin waveform, that's called loss of alveolar plateau, and it's an indication of bronchospasm. Their numbers are going to be higher as well because of their CO2 retention. To treat that asthma patient, we're going to make sure that they're oxygenated, make sure that they're moving enough air, and if not, start with basic measures and work our way up. Put them in a position of comfort. We want to provide some sort of humidified oxygen rather than just dry. Their mucus is going to be quite sticky and dry, and so being able to humidify your oxygen, or if you give a breathing treatment, humidify that oxygen that's going in. CPAP is something that certainly is being used in the treatment of asthma. It may help drive some of that fluid out of the smaller airways. They've seen some benefit, not huge benefits like you see with acute lung injury or ARDS or non-cardiogenic pulmonary edema or even cardiogenic pulmonary edema, but they have seen some improvements in patients when you use CPAP. You're going to measure, get your monitors out, get your pulse oximeter, your capnography, your cardiac monitor, and measure those parameters so that you can trend. Give them some sort of breathing treatment, and there's a variety of breathing treatments out there, certainly parental albuterol. Albuterol is the most common breathing treatment that people are using. It is beta 2 selective. It's not supposed to increase the heart rate, but it certainly can in some people. Excuse me. I'm going to have to pause for 1 second. Okay, I had had a brief pause there. I apologize for that, but we were talking about nebulizer therapy, and albuterol being the most common one. People will do duonebs, and duonebs is Atrovent and albuterol. And a duoneb, it has not only an additional beta agonist, but it also is a anticholinergic, so it helps dry up secretions. So when you're doing a duoneb, you're not only increasing the dose of the bronchodilator, but you're also helping dry up maybe some of those mucus secretions. And then Xopenex is another one. Xopenex is a nebulized therapy treatment that truly is beta 2 selective. It's a 3rd generation bronchodilator and causes little, if any, increase in the heart rate. IV corticosteroids certainly are adjunctive therapy. They do take, steroids take a while to work, so the sooner you can get them going, the better. Theophylline is something that certainly is being done. If the patient is in severe distress, we can give some epinephrine IM, 0.3 to 0.5 milligrams of epinephrine intramuscularly. and they're doing other things with helium. There's just a wide variety of different interventions that are out there, but in EMS we're primarily limited to nebulizer therapy and then epinephrine for imminent respiratory failure. Be alert for status asthmaticus, and that certainly is an asthma attack that doesn't break with standard therapies, and look for signs of respiratory failure. Respiratory distress, they're going to be working hard and have all those signs and symptoms, but when their mental status changes, then we're thinking more about respiratory failure, and we have to be more aggressive with that than we are with distress. Okay, moving on to the next slide. Bronchiolitis is another form of obstructive and restrictive pulmonary disease. It's an acute, so a sudden infectious inflammatory disease. It can involve both the upper and lower airway tracts, and it's the result of obstruction of the smaller airways. Some risk factors for bronchiolitis include low birth weight, crowded living conditions where things like upper respiratory infection bugs are common and are shared easily. Same thing with daycare, exposure to smoke, chronic heart and lung diseases, and RSV, or respiratory syncytial virus. Some of the history and physical findings you're going to have with bronchiolitis is the bronchioles are going to be obstructed from inflammation and swelling. You're going to have hyperinflation of the lungs. You're going to have increased wheezing because of the bronchospasm, and maybe some coarse crackles in the lungs themselves. The one thing that differentiates bronchiolitis from asthma is that typically with bronchiolitis, these patients are dehydrated, and as a result of being dehydrated, do respond favorably to a fluid bolus. So there'll be some significant atelectasis because the smaller airways being obstructed. Those alveoli, if not inflated, over time will collapse and stick to each other, causing the atelectasis. And you'll have the dehydration, tachycardia, tachypnea. They'll be working hard to breathe. You'll be seeing some nasal flaring. Grunting is something that you see in all forms of severe respiratory distress, particularly those involving the lower airways. Grunting is our attempt at providing physiologic PEEP, or increasing our own positive end expiratory pressure to help stent those airways open. They may be cyanotic. They may have all kinds of lung sounds, from crackles to rhonchi to wheezing, and rarely does bronchiolitis lead to apnea. Some therapeutic interventions for the treatment of bronchiolitis include, supporting the ABCs, put them in a position of comfort, hook up your monitors, pulse oximetry, capnography, heart monitor as well. You want to keep their O2 sats greater than 95%, and you do that certainly with supplemental oxygen and nebulized breathing treatments, since this is an inflammation of we want to use nebulized beta agonists or our normal breathing treatments, because this is a disease of narrowed and swollen lower airways. And then hydrate them, as I mentioned earlier. Now, cardiopulmonary dysplasia, that's a child who needs O2 supplementation at 28 days in order to maintain PO2s of 50. Normal PO2, as you remember, partial arterial pressure of oxygen, is somewhere in that 80 to 100 range. It's the result of inflammation and scarring of the smaller airways and the alveoli. It can be caused by prolonged positive pressure ventilation and high percentage of O2 concentrations. So when we're dealing with particularly babies in that first 28 days, we have to be really careful about prolonged 100% positive pressure ventilation with oxygen. It's one of the reasons we no longer do 100% oxygen tents for kids anymore as well, because of the potential development for hyperoxygenating them and them developing bronchopulmonary dysplasia. This is going to be a premature baby who's tachypnic and tachycardic with retractions and nasal flaring, all the classic signs of respiratory distress. So the need to ventilate them with a bag valve mask is there, but not necessarily with 100% O2. You're going to listen to lung sounds. You might hear the full gamut, from crackles to rhonchi to wheezes. We're going to give them oxygen, but in this particular case, just to maintain SATs between 90 and 95%. We're going to keep them just slightly hypoxic so that we don't, in fact, give them too much oxygen. COPD is certainly a catch-all phrase, but most of us, when we hear the term COPD, we think of emphysema. But COPD, chronic obstructive pulmonary disease, includes bronchitis, emphysema, asthma, and a varying degree or combination of any of the above. Now, COPD is caused by long-term tobacco use, exposure to secondhand smoke, exposure to inhaled toxins. Miners get COPD, farmers get COPD from grain bin dust, miners from coal mine dust. So chronic exposure to inhaled toxins. Bronchitis is the predominant COPD, and it results in an overproduction of mucus. There's a cell enlargement in the lungs and the airways. It typically can have a really productive cough, for 3 months up to 2+ years, on and off. With the overproduction of mucus, the alveoli don't get fully inflated, and that has a tendency to drop the O2 level in the blood, which certainly, if significant enough, could lead to respiratory acidosis. One thing that the body does in an attempt to get more oxygen into the blood during a chronic state like this is to elevate the blood pressure, so the blood pressure is going to be slightly elevated, and increase more red cells so that you have more oxygen carrying capability. If chronically you have this obstructive pulmonary disease where you can't oxygenate well, those are some compensatory mechanisms that your body will attempt in order to increase oxygen carrying capability of your blood. And then here's just a picture of the normal lining of the bronchioles and the terminal bronchioles, and that during bronchitis the bronchial walls become inflamed and mucus is overproduced and accumulates in those airways and has to be coughed up. Emphysema actually involves the alveoli, not the bronchioles. It's a destruction of the alveoli and destruction of the elastin fibers surrounding the alveoli, and emphysema, much like bronchitis, is caused by chronic tobacco use as well as inhaled toxins, and leads to chronic hypoxia and hypercarbia. So people with emphysema, because of the disease and how it destroys the alveoli, have difficulty getting rid of their CO2 and onloading O2 into the blood, so they're chronically hypercarbic. Emphysema leads to blebs on the lung surface as well from those damaged alveoli, and those blebs certainly can rupture, causing a pneumothorax. Polycythemia is something as well that can occur with emphysema. Most emphysemic patients have a big barrel chest because they're unable to get all the air out because of the air that's being trapped in the alveoli, which remains stagnant and certainly can lead to chronic lung infections like pneumonias, those sort of things. But they also have a tendency to be very malnourished in appearance, muscle-wasted, emaciated, big barrel chest, pursed lip breathing, and because their oxygen saturation remains pretty good, it's their CO2 that's out of whack, they don't have a tendency to be cyanotic. You may have heard of the folks with emphysema being referred to as pink puffers. Their skin is relatively normal color. They aren't cyanotic, and they purse their lips in order to increase positive end expiratory pressure and try to stent those alveoli open themselves. People with emphysema are chronically short of breath. They may have little or no cough and really little mucus production. But the air trapment and the CO2 levels can be high enough that certainly if they get any sort of normal winter cold, it may have a tendency to lead to pneumonia, bronchitis, all that sort of stuff. And hypercarbia over long periods of time affects the mental status, and you may see some mental status changes if the hypercarbia is severe. COPD also leads to heart problems, cor pulmonale, which is that whole right ventricular hypertension, pulmonary hypertension, and then ventricular failure as well, particularly that right ventricle because of cor pulmonale. Asthma, we already talked a bit about asthma, but it is in fact a COPD. It's the bronchial hyperstimulation, constriction, the increased production of dry mucus, leading to wheezing and shortness of breath. When treating a patient with COPD, we want to oxygenate them and ventilate them. And we want to at least get their SATs up to 90% or better. It's probably normal for them to run SATs in the less than 94%. They're probably chronically like that. And so, if we get a COPD patient who really isn't working super hard to breathe and their SATs are 92%, that's probably normal for them. And unless they're complaining of an increase in their normal shortness of breath, wouldn't require much oxygen at all. So get their SATs up to at least 90. The other thing to keep in mind about COPD is that chronic retention of CO2 causes CO2 narcosis in the respiratory center in the brain. And as a result of that, COPD patients don't breathe off their CO2 drive. That part is anesthetized in the respiratory center of the brain because of the chronic high CO2. So they rely on their oxygen level. When their oxygen level gets high enough, then they slow their breathing rate down. Where you and I, we're going to rely on our CO2 level to determine whether or not we increase our rate and depth of breathing. If you have the ability to administer anything to help reduce bronchostriction, airway secretions, certainly breathing treatments, patients may benefit from some sort of bronchodilator. Gain IV access monitors. Put all your monitors on, your ECG monitor, pulse oximetry, capnography. You can do some peak expiratory flow testing, and again, one of the important things that we glean from peak expiratory flow is that if you get a baseline and you know what their peak expiratory flow is, and then you administer a treatment and it doesn't get any better at all, there's two things you can take away from that bronchoconstriction is not their problem, or your treatment was just ineffective. And then transport and reassess frequently. Cystic fibrosis is another obstructive or restrictive pulmonary disease. It does lead to pulmonary distress complications, With cystic fibrosis, you get a thick, sticky mucus in the bronchioles, but you not only get that in the bronchioles, but you also get a thick, sticky mucus that blocks the pancreatic and bile ducts. So the ability to secrete bile and pancreatic juice to help with the digestion of amino acids, fats, those sort of things, is hampered in people with cystic fibrosis. And cystic fibrosis is the result of this particular gene, CFTR, on chromosome 7. With cystic fibrosis, the secretions become thicker in those airways and in those tubes. Again, it affects the lungs as well as the liver and the pancreas. It's more common in white people. And the median lifespan of somebody with cystic fibrosis is about 36.8 years in age. So if diagnosed with cystic fibrosis young, it is understood that's a disease that has no cure and certainly decreases a person's lifespan. Some of the history and physical findings that you're going to have with cystic fibrosis is that because it's the result of an excess secretion in the bronchioles, it's going to present similar to COPD and pneumonia. There's going to be a cough. They're going to be short of breath, crackles, wheezes, rhonchi, all that stuff may be present. Their chest wall may be tender. They may be running a fever. And we're going to try to improve their oxygenation and ventilation and know where they're at with the baseline pulse oximetry, end-tidal CO2, hook them up to a heart monitor, provide some supplemental oxygen ventilation. Certainly a breathing treatment wouldn't be out of hand in order to perhaps dilate those bronchioles, so maybe we could get a little air by there. Pneumonia is another obstructive and restrictive pulmonary disease, and pneumonia is an infection in the terminal breathing spaces or the alveoli. So you can have bronchial pneumonia, which is pneumonia in the alveoli, or lobar pneumonia, which infects an entire lobe. Now, pneumonia can be the result of a disease. Pneumonia is, let me take that back. Pneumonia is a disease caused by a virus. It could be the RSV virus. And we don't see a lot of RSV here in the United States as much as they do in Canada and certainly in China and European nations. They see a lot more RSV. The parainfluenza virus, influenza, and adenovirus are what we see most commonly here in the United States. Influenza H1N1 being a major cause of pneumonia. Pneumonia accounts for about 1,200 deaths a year in Iowa, and we're right in the thick of the influenza season. Pneumonia can be caused by a bacteria as well, Haemophilus influenza, Streptococcus pneumoniae, Cycloplasma, whatever, Klebsiella, and Pseudomonias are all bacteria that can cause pneumonia. And pneumonia can be caused by a fungi as well. It's been said that, as an example, untreated mulch, where they have these big piles of mulch that people are free to come and take, of trees that have been taken and shredded and just left in a big pile, and people can take it home and put mulch around their homes. That develops a mold or a fungi, and then if you don't wear respiratory protection while you're handling it, you certainly can get a pneumonia from that. You can get really sick from that. Cleaning up mouse droppings, bat droppings, those sort of thing also release a spore or fungi that can cause a nasty pneumonia. Lobar pneumonia is localized to one or more lung lobes, and here's a picture of an unhealthy lung with pneumonia. Bronchopneumonia is an inflammation around the medium-sized airways. You get a patchy consolidation of parts of the lobe, but not the whole lobe itself. And interstitial pneumonia is lung tissue inflammation between the air sacs. Now the typical pneumonia signs and symptoms are going to be acute onset, fever, chills, productive cough with a thick green, purulent, maybe even bloody sputum, pleuritic chest pain. On X-ray, you're going to see some pulmonary consolidation. You're going to hear, you're going to hear rhonchi if there's a lot of liquid in there. You're going to hear crackles if there's a little. You may not hear much if they're not moving much air. And as I said, you're going to hear crackles. The patient's going to be lethargic because they're not exchanging oxygen, so they don't have a lot of oxygen to make energy. They're not going to feel like eating. Their heart rate's going to be up. Their breathing's going to be up. And they may have pain on that side of the chest where the pneumonia is, and also the back. Atypical pneumonia is pneumonia where we have a non-productive cough. We have extrapulmonary symptoms like headache, muscle fatigue, sore throat, nausea, vomiting, and diarrhea, fever and chills. Might be, construed as perhaps the flu rather than pneumonia. Complications that certainly make pneumonia more difficult to treat, as well as make pneumonia carry a higher mortality rate, include age. Excuse me. Again, I mentioned that the very old certainly don't tolerate pneumonia well. If a person has pre-existing chronic obstructive pulmonary disease and they get pneumonia, that can be lead to death as well. Patients with heart disease, alcoholism, diabetes, AIDS, alcoholism certainly because of the suppression in the immune system and the body's ability to fight disease in general. And diabetes has a tendency to complicate many other diseases, particularly type 1 diabetes. And then AIDS because there's a relatively non-lethal pneumonia that occurs commonly in AIDS patients that can lead to their death. And it's because of the immune suppression. If we think our patient has pneumonia, we're going to optimize oxygenation, monitor the respiratory status with pulse oximetry, end-tidal CO2, heart monitors, establish an IV, consider some CPAP if we don't get improvement in oxygenation with a cannula or mask. And if CPAP isn't successful, then we need to do a rapid sequence airway and then think about endotracheal intubation. Patients in pneumonia develop sepsis, so be alert for septic shock. And if a person were to have septic shock, certainly they would be hypovolemic and would need lots of volume, as well as antipyretics if they're feverish. They would need to be put on antibiotics as soon as possible. And if it's a bacterial pneumonia, certainly, either viral or bacterial, those are pneumonias that you don't want to get. So wearing a mask and protecting yourself from droplets as they cough and hack is important. Lung abscesses, that's pus that collects in the lung. It's often the result of aspirated gastric contents. So, people that might aspirate even the smallest amount of a teaspoon of gastric contents, that can lead to anything from a lung abscess to a full-blown acute lung injury, to ARDS, to death. You'll get a history and physical finding in somebody with a lung abscess that they had they now have a productive cough, and that the cough has a real, the sputum has a real unusual odor. They'll be short of breath, they'll have a fever, they'll have night sweats, decrease in appetite, weight loss, chest and chest wall pain. And so many of these symptoms of lung abscess are extremely similar to tuberculosis, extremely similar to AIDS, extremely similar to pneumonia. So it's very difficult to differentiate this in the field. They may have a low-grade fever, be tachypneic, tachycardic, have all kinds of lung sounds from coarse rhonchi to crackles to wheezes. Their lung sounds may be diminished if they're breathing shallow, or certainly if the lung is abscessed, they're not moving any air through that particular lobe. Edema or the pus can collect outside the lung in the pleural space as well. We're going to give them supplemental oxygen, supportive care, certainly monitors to see how well they're oxygenating and ventilating, pulse oximetry, end-tidal CO2, and if we cannot get SATs up with supplemental oxygen, there's not a lot of research that would indicate CPAP would be something that we would do for lung abscesses, but we may have to rapid sequence induction and intubate if we can't get their SATs improved. Aspirate pneumonia and pneumonitis, something that occurs as a result of gastric acid or food that's aspirated. It's an acute inflammatory response. It leads quickly to hypoxia and respiratory failure. Aspirate pneumonia and pneumonitis is the primary cause of an acute lung injury, which certainly can lead to acute respiratory distress syndrome and death. Those patients at risk of aspirate pneumonia include anybody with an altered mental status, anybody who's intoxicated, belly's full, anybody with chronic disability, some sort of chronic medical condition, people who have feedings with G-tubes, if they've got a history of stroke and they are not swallowing properly. That's one of the assessments that they'll do on stroke patients is how well are they swallowing, how well are they able to swallow, because oftentimes following a stroke it may affect their ability to swallow and put them at greater risk of aspiration. Somebody with head trauma because of the altered mental status and the vomiting, and then anybody with a altered mental status and who's unable to control their airway and has presumed full stomach. With aspiration pneumonitis, you have lung and bronchoalveolar irritation from aspirated stomach acids. The alveoli swell, they increase excessive mucus production, and with aspiration pneumonia, that's bacteria that settles in the lower lungs, may cause a pulmonary abscess and lead to a full-blown pneumonia. The history and physical that you're going to see in patients with aspirate pneumonia and pneumonitis, they're going to be short of breath, have altered mental status, fever, chills, dyspnea on exertion, can't lie flat at night and breathe, their chest is going to hurt when they take a breath, their cough is going to be productive, they're going to be in respiratory distress, and to treat it, it's all aimed at improving oxygenation and ventilation, as most of our respiratory problems are. We've got to get aggressive in managing hypoxia and hypercarbia when we see it by ensuring adequate oxygenation and ventilation. Not sure that patients benefit much from things like breathing treatments, but you'll still see people with pneumonia being given a breathing treatment. And in this particular case, it's not in my opinion, beneficial. Gain IV access, heart monitor, end-tidal CO2, pulse oximetry, all the standard stuff. Pulmonary tuberculosis, it's a disease, it's a pulmonary disease caused by Mycobacterium tuberculosis, and it's transmitted via airborne droplets, and it comes in different stages. Stage 1, the bacterium is inhaled into the lungs, and you get a standard inflammatory immune response that's triggered. If defenses contain it, then your body eradicates the bacteria and it doesn't progress to TB. In stage 2, the bacteria multiply rapidly. Tubercle are formed in the infected lung area, and the infection spreads throughout the lymphatic system and the vascular system and out throughout the body. There are some extrapulmonary causes of tuberculosis as well, and tuberculosis can lead to pericarditis, peritonitis, GI disease because of its spread throughout the body. Stage 3, the tuberculosis occurs 2 to 3 weeks after the first stage, you have an inflammatory immune response that contains the spread of the infectious organisms. Granulomas are formed, tissue destruction occurs, and then it lies dormant for years inside the lung tissue or wherever it settles. And that's why people who have are required, when you're around healthcare, you're required to have a TB test at least every other year, and once you test positive for TB, then you don't get the TB test, you get a lung x-ray yearly to make certain that it's not active again. Stage 4 is when the dormant bacteria reactivates, the tubercle erodes, it releases contained bacteria back into the lung. Patients with tuberculosis, active tuberculosis, will have a productive cough, a fever, weight loss, coughing up blood, chest pain, fatigue. They'll be irritable, weak, headache, fever, chills, night sweats. Again, could resemble a variety of other chronic respiratory conditions. The elderly may have an atypical presentation of tuberculosis. They may just have a chronic cough, failure to thrive. They're not going to have as many respiratory symptoms, but fever, shortness of breath, rales, and upper lobe affinity. It has a tendency to settle in the upper lobes. To treat a patient with tuberculosis, we want to get a detailed history of potential for TB exposure, and then initiate respiratory isolations, droplet precautions with masks. Notify the ED ASAP if you believe the patient has tuberculosis, and it's an emergent risk. It's a droplet infection risk, so wearing a mask and having the patient wear a mask is extremely important. Pulmonary thromboembolism is a pulmonary embolus that lodges in a pulmonary artery, and of course with a pulmonary thromboembolism it obstructs the flow of blood by the alveoli, so gas exchange cannot take place. They often start in the leg, and they go through the inferior vena cava into the right ventricle and then get lodged in the pulmonary artery. They're difficult to diagnose because there's a wide variety of clinical signs, and if significant, if you get a saddle embolus that sits right there in the saddle, a very large PE that obstructs both pulmonary arteries and pulmonary veins, you completely shut the circulation off to the lungs, and you develop severe hypoxia and hypercarbia and die. There are certainly conditions that favor the development of a pulmonary embolus. Inability, long periods of stasis, injury to vessels or the lower leg, those things increase the risk of developing PEs. Virchows Triad refers to things like a sedentary lifestyle, hypercoagulation, a history of hypercoagulation, and damage or injury to the lower extremity. So if you've got those three things, that's a prime set of conditions that increase your risk of developing a DVT. Smoking increases your risk of DVT. If you have a history of deep vein thrombosis, you're certainly at greater risk of a PE. Long bone fractures, you can develop clots which can again break free and travel to the lungs. Pregnancy increases your risk of pulmonary embolus. Recent leg or hip surgery, especially if you've been lying around for a long time, which they won't let you do in a hospital anymore. I mean, typically people are up and on their feet the first day following knee or hip replacement surgery. And excuse me. What? Okay, sorry for a little pause there, but I had to take care of a little business. So we're back here. We're talking about the history and physical findings related to PEs, and certainly we had talked about recent leg or hip surgery and how they don't let you lie around in bed anymore. They get you up and get you moving so that you don't develop that PE. And if you're unable to do that, they put you in a machine that moves your leg up and down, back and forth, to decrease the likelihood of developing a PE. Those patients who take contraceptives certainly are at greater risk of a PE. And then those who are in a stasis of position for a long period of time. Long trips, 8-hour flights, 8-hour road trips, and you don't get out much and move around. In a long bone cast, for months on end, not moving that extremity, and then all of a sudden you get the cast off and start moving it, and a person's at a greater risk of PE in that situation. What we see with the pulmonary embolus is what's called a right-to-left shunt, and in that particular case, it's a ventilation perfusion mismatch. And what happens is you've got oxygen flowing to the alveoli, but because perfusion is inadequate, the blood flow is obstructed by the alveoli. You're not able to eliminate CO2, but you're not able to onload oxygen either. So your patient's going to be hypoxic. You may see evidence of pulmonary hypertension. You may see evidence of right heart strain. And right heart strain, you'd look at that lead 2, 3 in AVF, and that right coronary artery, and if you had significant depression in those 3 leads, ST segment depression, T-wave inversion, that would indicate that part of the heart is being strained. It's ischemic. It may be related to, again, a limited blood supply through a pulmonary artery as well as through a coronary artery itself. But with a PE, the thing that you'll see is you've got this low pulse oximetry. Lungs are going to be clear because they have no trouble getting air in and out of the lungs, but their SATs are low, and you give them 100% oxygen, and their SATs don't get any better, or get minimally better. They may be hypotensive. PEs come on acutely in most all people. They may have pleuritic chest pain that gets worse when they take a breath in. They're going to be anxious because, of course, they're hypoxic. They're going to be tachycardic. It may be associated with a fever, particularly with DVT. They may have a dry cough, raspy kind of cough. May have a dry kind of cough. May have some mucus production, but typically it's not a real productive cough. They're going to be tachypneic. Their skin is going to be pale, cool, possibly cyanotic, and if they are hypotensive, they have a shock index greater than 1, and I'm not real familiar with the shock index, so that may be something we'll have to look up. Okay. You're going to give them supplemental O2, and you're going to give them an IV access. And one of the diagnostics that certainly you can use is a 12-lead ECG, and you look at the S wave in lead 1, you look at the T wave in lead 3, and you look for a Q wave in lead 3. And when you see that, there's about a 25% chance that could be caused by a PE. So here's a 12-lead ECG in somebody with a PE, and you can see that you've got some ST depression in lead 1. You have some ST depression. You have a Q wave in lead 3, and you have an inverted T wave in lead 3. So I'm looking at lead 1 and lead 3, and I have a depressed ST segment. I have a Q wave and a inverted T in those 2 leads. And when I see that in a patient that presents with a sudden onset of shortness of breath and maybe has a history of stasis and DVTs and whatnot, and their SATs don't get any better, when I administer 100% oxygen and I hook them up to a monitor and do a 12 lead, and I see that, there's a 25% chance that's caused by a PE. Well, hyperventilation syndrome occurs when somebody excessively ventilates, when somebody breathes deep and rapid. So it's rapid breathing and deep breathing. It leads deep and rapid breathing is also called hyperpnea. And it can lead to respiratory alkalosis caused by increased CO2 elimination. Typically, hyperventilation syndrome is preceded by a stressful or an emotional event. People feel like they're suffocating, they're not getting enough air, and the longer they blow off that CO2 and the more respiratory alkalosis they produce, they develop a tingling in their fingertips and the toes and around the mouth. They may also develop some chest pain, dizziness, and lightheadedness, and of course all that feeds into yet even more anxiety. So some physical findings with hyperventilation syndrome: the patient may be agitated, anxious, definitely tachypnic, tachycardic, have some generalized weakness. If they have low potassium levels or borderline potassium levels, you might see some carpal pedal spasms. They may pass out. Their SATs are going to be 100%, their lungs are going to be clear, and they may have Trousseau's sign, which is something I'd like you to look up because frankly I didn't, so I'm not familiar with that, but you certainly can look that up, and I will as well. Therapeutic interventions for hyperventilation syndrome: no longer do we give them a brown paper bag and tell them to breathe into a brown paper bag, because if there are other conditions that cause deep and rapid breathing, like diabetic ketoacidosis, where they're breathing deep and rapid to blow off CO2, and if we have them breathe into the bag, they'll rebreathe that CO2 and actually make them worse. So we need to coach them to slow their breathing down. You certainly can put some oxygen on them, although they don't need it, gain IV access, and maybe even give them maybe even give them something for their anxiety to help them calm down. Now, atelectasis is a collapse of the alveoli in some parts of the lungs. When we breathe, we don't really fully expand all the lobes of the lung. As you know, we certainly at times will take a really deep breath, we'll yawn, we'll take a really deep breath and cough, and these are modified forms of breathing that our bodies do in order to expand those collapsed alveoli. The problem with atelectasis certainly is that if these alveoli are collapsed, they're not not playing in gas exchange, so they're not exchanging oxygen and CO2, and you've got those chemoreceptors in your bloodstream and in your brain and in your carotids that are constantly looking at things like your O2 level, CO2 level, that sort of stuff. And when those get out of whack, the respiratory center is stimulated to perhaps yawn, sigh, maybe even take a really deep breath and forcefully cough. These are things that our body will do in an attempt to open up those collapsed alveoli. Atelectasis occurs after surgery, certainly in somebody who's sedated and not breathing deep. You're at risk of pneumonia as those alveoli are collapsed and what's in there is stagnant. And again, we prevent atelectasis naturally by regular coughing and a deep breathing like a sigh. Some history and physical findings: you certainly can see atelectasis on a chest x-ray. There'll be some chest wall pain, shortness of breath, they may be coughing, they may have a fever if it leads to pneumonia. They're going to have the crackles or the snap, crackle, pop on inhalation. That's the alveoli snapping open or popping open that have collapsed. End-tidal CO2 is going to be decreased with severe atelectasis. Encourage them to take a deep breath. If they're conscious, force them to take a deep breath with CPAP. Give them some oxygenation, IVO2 monitors, monitoring end-tidal CO2 and pulse oximetry. Now, tumors can be benign, which are non-cancerous, or they can be malignant, which are cancerous. There are primary tumors and secondary tumors. And here is a tumor seen on a regular chest x-ray, and then also later on a PET scan. So they can see the tumor in the lung. If undiagnosed, tumors cause malaise, dyspnea on exertion, coughing up blood, weight loss, and many patients, of course, with a long smoking history are at greater risk of developing lung tumors or lung cancers. They may be thin or emaciated, pale, may have a cough, maybe coughing up blood, fever, may have some narrowing of the upper airways if the tumor is in the upper airways, wheezing if the bronchioles are narrowed as well, all kinds of lung sounds from crackles to rhonchi to wheezes. They'll be short of breath, have chest pain, low sats. They may develop a pulmonary effusion, which you would see on a chest x-ray as well. You may hear a friction rub. The breath sounds may be absent or diminished, particularly in the lower lobes. In a patient with a tumor, again, our goal is to improve oxygenation and ventilation by giving them oxygen, assisting their breathing, find out if they do have an advanced directive, should they stop breathing, determine whether they want to be resuscitated. Bronchodilators may help with bronchoconstriction, and certainly if they're in a lot of pain with their tumor, we do have the ability to relieve pain with morphine or fentanyl. Environmental and occupational inhalation exposures occurs when you mix chemicals, particularly hydrocarbon solvents. We would never want to mix bleach and ammonia together as a cleaner, because that gives off a deadly gas. And then using hydrocarbon solvents in an enclosed space, like paint thinners, strippers, those sort of things, will lead to asphyxia. Some of the history and physical findings are going to be very similar to asthma. The patient's going to be short of breath, wheezing, tachypneic, anxious, coughing, maybe tearing and drooling. We want to get them out of the area of the offending substance, get them out of the house, get them into fresh air, don't become a victim yourself, ventilate the home, suction, positive pressure ventilation, oxygen, you got your O2 sat, your pulse oximetry, all those things. If they're wheezing, an inhaled beta agonist might be appropriate. You want to identify what the agent or chemical was, perhaps even request or look up the safety data sheet on that particular chemical, and then if the patient body was exposed to it and they got it trapped between their clothing, or if it was in liquid form and it's all over their clothing, or in powder form, then you might have to provide decontamination. Oxygen-powered ventilators. This is the simplest of transport ventilators with a two-knob system where you set your tidal volume and your ventilatory rate. It hooks up to an oxygen source, usually delivers 100% oxygen, so you've got to have a lot of oxygen in your vehicle to do that. Some of the other oxygen-powered transport ventilators have three dials that you can assess. You can set inspiratory time, you can set tidal volume depending on whether you're adult or a child, and you can set respiratory rate. Things that you're not able to do with this is adjust your FiO2 to deliver a certain percentage of oxygen, or add positive end expiratory pressure, or PEEP. Synchronous intermittent mandatory ventilation, or SIMV, that's inspire at will. You'll set a default rate, and this works well in patients who are partially or mostly awake. Non-invasive mechanical ventilation includes CPAP. CPAP delivers positive pressure constantly. CPAP, constant positive airway pressure. It can be used in patients with neuromuscular weakness. It's great in any patient with pulmonary edema. It's used routinely in patients with obstructive sleep apnea. So it's recently been added to the Iowa protocol to allow the basic EMT to use CPAP because of one, how beneficial it is, and how safe and easy it is when you follow the protocol. A wide variety of CPAP equipment. Here certainly is an older slide showing you the whisper flow and all the different equipment that goes with it. There's a variety of plug-and-play devices now that you just plug right into your regular oxygen outlet in your ambulance. Costs about $35 for a whole setup, and when you get to the hospital or you get ALS arrives, you just unplug it and plug it right into their oxygen, and you don't lose any of that continuous positive airway pressure. With this sort of setup, although it works great, it is a hog for oxygen, and if the hospital doesn't have the same device, when you get there, you got to switch everything, take it all off and hook all theirs up, and some valuable time is lost that way. Non-invasive mechanical ventilation, here they're talking about BiPAP. CPAP is continuous positive airway pressure. BiPAP is continuous pressure, but it's bi-level. In other words, the inspiratory pressure is greater than the expiratory pressure. And the reason for that is BiPAP works well in patients who are tired. Their work of breathing has fatigued them, and they're finding it difficult to take that breath in. So having a little greater pressure on inspiration helps them take that initial breath, and then exhaling against pressure helps stent those alveoli open and improve oxygenation. A thing to mention about both CPAP and BiPAP, neither of them are mechanical ventilators. They by themselves will not ventilate your patient. That's something that the patient has to do. Some signs of imminent respiratory failure include certainly altered mental status, decreased muscle tone, decreased response to pain, increased respiratory rate, effort, and chest exertion, tachypnea with periods of bradycardia, slowing to bradycardia and then agonal breathing, or slow breathing, diagonal breathing. So initially with hypoxia and respiratory failure, severely hypoxic, severely hypercarbic, you're going to be working hard to breathe, but your heart rate's going to start to drop with increased hypoxia and hypercarbia, and then your breathing gives out as well. Causes of respiratory failure include chest trauma, head trauma, TIA, COPD, status asthmaticus, severe pneumonia, intracranial hemorrhage, drug or alcohol intoxication, tension pneumothorax, severe aspiration, severe congestive heart failure. So all these conditions lead to respiratory distress, and if not fixed, will lead to respiratory failure. Management for respiratory failure, when you see it, is you got to get aggressive. It may require immediate endotracheal intubation and mechanical ventilation. All right, so with that, we end the pulmonary section. I want to thank you, and I'll talk to you soon.